Hi everyone. So I'll try to keep it to the 7 minutes. So I'm speaking about this qualitative study I did alongside my colleagues at Vincent, trying to understand the lived experience of undergoing HSCT for MS, which is a stem cell treatment. So I suppose a little bit of background for people who might know much about it. It was first used as a treatment for MS in the 1990s. And it aims to reboot the immune system. And this is done by extracting the patient's stem cells and then administering high doses of chemotherapy to eradicate the immune system, and then reinfusing the patient's own stem cells in hopes that it'll rebuild the immune system. And the goal is to induce long-term suppression of new focal inflammation. So there's been clinical trials that have shown high rates of efficacy for particular presentations, so people with relapsing forms of the disease, with high levels of disease activity, and that are resistant to disease-modifying therapies. Most research to date has focused on disease outcome measures. There's very few studies on patient-reported outcomes, neuropsychological outcomes, and very few qualitative studies. There were 2 published in 2024, and then we published this one as well. So there's a lot of things to consider when considering this treatment for people who have MS and also their healthcare teams. So it's a really intensive treatment regime with a 6 to 12 month recovery process, and during that time there's risks of infections, secondary autoimmune conditions, and for some patients risk of chemically induced menopause and altered fertility. And then treatment availability, so you currently can't get the treatment in Ireland. If somebody meets the clinical criteria, they can be funded to get it under the NHS. But if they don't meet the clinical criteria, they have to look further afield and self-fund. And of course that has huge financial implications, but either way, even going to the UK as well, going to get a treatment abroad in any situation has time implications, cost of travel and accommodation, and then also you're away from your social support network during a time that's really challenging. So we wanted to try to understand the lived experience of undergoing HSCT for MS with the hope of informing the provision of care and service development for people undergoing this treatment. And we used a thematic analysis approach. So it was a qualitative study, so we did qualitative interviews, and we had 12 participants in total who were really generous with their time and talked through the experience, the different challenges they faced, and how it was for them. So a big thank you to all the participants who gave their time. So there was we looked at people who had undergone the treatment in the last 10 years. So it ranged from 6 months since the treatment to 8 years. And most people had gotten the treatment in the UK and were funded to get it there. But 4 people self-funded and went further afield to Russia or to Mexico. So I'm going to try to give an overview of these themes in the few minutes I have remaining. There was 3 overarching themes. There was so much rich data, and this was just one way to kind of put a bit of structure on it. So the first theme was balancing hope and fear when considering the treatment, and there was 3 sub-themes under this. So the first was weighing up the risks. So a quote here: "Without it, I was gone. I was gone. I was a goner, really. Maybe I wouldn't be dead, but I wouldn't want to be alive, with someone feeding me and all that." And this sub-theme is really around weighing up the risks of getting a strenuous treatment like HSCT that does have its risks, but also thinking about the risks of not getting it and the fears of MS progression. The next sub-theme was managing expectations. And this quote: "Hopefully it'll slow down, or it will, send it into remission. That would be good enough for me." And then the other side, which is magical thinking, which was, I'll be able to walk and maybe I won't need a stick. So I suppose this highlights that the main driver for getting the treatment for all the participants I spoke to was halting progression of the disease. But of course there was kind of a bit of hope for some symptom improvement, which isn't always guaranteed, and the people I spoke to just talked about trying to manage those expectations. And so that was tricky. And the third sub-theme then, not just a number. So this was really highlighting the importance of, when considering HSCT, having their personal values, personal circumstances, and personal reasons for wanting HSCT to be included in the healthcare discussions around their treatment. Some felt frustrated with the strict clinical criteria and wanted to kind of have a bit more of a conversation around it. And some people who did go further afield for the treatment talked about being a little bit fearful if they didn't get their consultant's blessing to go, that they were fearful of what their care would be like on returning. That was just a worry that some people talked about having. So the quote, "We're not, in a sense, just numbers or the name, we're people as well, you know." So the second main theme, there was so much in everybody's experience that this was, I suppose, to capture it, that it's clearly a time of heightened emotion, but that everyone's journey through the treatment process was really different and everyone had a unique experience. And this quote here, "I was very anxious during that whole period," that's referring to the recovery time, because, you know, there were a couple of times where I was a little bit worried and thought, oh my God, you know, what have I done? Have I traded in MS for something far more sinister? So that's talking about the anxiety during that recovery time and worry about where it was going and had they made the right choice. And the third overarching theme was adjusting to outcomes following HSCT treatment. And the first one was finding value. So a strong narrative throughout the interviews was the absence of regret in getting the treatment. So the people I spoke to, for some it did hold progression, and for some they did have progression of disability. They spoke about being frustrated that it didn't work, but being glad that they had tried it, and that they felt a bit more acceptance with where their MS was at following the treatment. Now this participant, I found it to be a great milestone in my life, and it's given me great peace of mind and helped me to move on with my life actually and do other things that I never would have done before. And the final sub-theme, navigation uncertainty, this refers to the recovery period and how to manage the challenges that arise during that time. And this specific quote referred to somebody who, and this was a common theme in the interviews, that there wasn't a clear pathway for people who had difficulties following the treatment, particularly ultra-fertility or chemically induced menopause. So this is this participant's experience of going and trying to get help for it. I was going in and saying, would you test my hormone levels because I think I'm menopausal? And they'd be like, oh, you're being ridiculous. And I'd explain the situation and they'd be like, oh no, you're far too young. Like, it's so frustrating. So that whole recovery time, not having clear pathways for care, was a big frustration for participants. So implications for care, I suppose one of the big things is a collaborative approach for considering HSCT, and a shared decision-making model might be really helpful in bringing together best available evidence and also the patient's preference, values, and having a conversation around that. I think it'd be really important to target emotional distress of HSCT, and there is research that distress in general across HSCT, across different presentations, can have impact on distress, and that psychological interventions can be beneficial for reducing depression and anxiety post-HSCT. And then, I suppose, really importantly, clear recovery pathways have to be established following HSCT. If there was a funded national HSCT service for Irish people with MS, that would solve a lot of the problems. Recently published consensus guidelines talk about needing to consider rehabilitation at each stage of pathway and using an MDT approach. And then I just put in there about menopause and infertility. That came up quite a lot in the conversations, that it needs to be clearly discussed beforehand and clear pathways laid out for care following the treatment. And then future research, so loads more research can be done on this, longitudinal studies after HSCT, factors that influence the emotional experience of the process, and then talking to people with MS who maybe have decided against HSCT. In this study, we included people who both met the clinical criteria for HSCT in the UK and those who didn't, so understanding their different experiences, and then research across primary care and tertiary services to see healthcare professionals' understanding of HSCT and what they feel they need to help them support patients would be really useful. That's that's the end. Thanks.